Hello, everyone, and welcome to LA Social Science, an e-forum really kind of created by the Division of Social Sciences and Dean Hunt. Once again, I had the immense pleasure of interviewing one of our outstanding faculty members here at UCLA. And, this faculty member is on the south side of our campus, but does the work of all of our campus as it relates to just real groundbreaking and necessary research. Dr. Helena Hansen, MD and PhD, is a psychiatrist and an anthropologist, and is the professor and chair of research themes in translational social sciences and health equity, and also is the associate director of the Center for Social Medical at the David Geffen School of Medicine. Did I get all that right, Doctor?
Yes, and it is a tongue twister. I can tell you a story about that in a moment. But yes,
Yeah.
I'm at the Center for Social Medicine at the med school, and also the research team at the med school in health equity and translational social science.
Well, I personally and professionally, I want to make sure I thank you, Doctor. The work you've done and what we're going to learn about today, I think hits all of us. After coming out the pandemic, just being of color in this country, the history that we have, having someone like you doing this research really gives me a new sense of hope. So, if you could, Doctor, can you tell us a little bit about your research?
Oh, definitely. And maybe I can start with the tongue twister that all of us stumble through.
Please, please.
So I've spent my career trying to bridge the social sciences with medical clinical research.
Mm.
And the reason is that in the US, we're just so enamored with biotechnology and individual level solutions to health problems. And a lot of that is driven by the commercial nature of our healthcare system. We're probably the most profit-oriented, privatized health systems in the world.
Mm.
And so a lot of what we do in academic medicine and training people and doing research and patient care is actually shaped by the interests of corporate medicine. And they're very interested in developing new medications, new devices, things that can be sold and marketed, as opposed to intervening on what we now call the social determinants of health.
Okay.
And in really looking carefully at what drives health inequalities by race, by gender, by class, by other hierarchies of oppression. That's the way we talk about it on the social science side, campus.
Yeah.
But on the academic medical side, that way of thinking is actually pretty foreign. It's beginning to penetrate a bit. But I would say that throughout my clinical training, it was rare to encounter in academic medicine places where the social was really taken seriously, and power inequalities, social drivers, what I call structural drivers of health inequalities, they really weren't well understood or taken seriously. And people on the medical school side who are doing research on health inequalities, because they're so stark in the United States, it hits you in the face. The inequalities are huge. And as a result, our health statistics overall are terrible. We spend the most of any country in the entire world on health care per capita. We spend almost 20% of our GDP, and we have the worst health outcomes of all industrialized nations. So we get very bad results. A lot of it is driven by structural factors, which I can get into in a moment, because we don't address them in our health policy. And so I saw this early on, when I was in college and just out of college. I came of age at the peak of AIDS activism. And I was really inspired as somebody who's trying to figure out how I could have an impact on health inequalities. I was really inspired by people who were going against the grain, community activists who, many of themselves who were HIV positive or affected by HIV, took to the streets, did a lot of organizing, did mutual aid campaigns, house parties in people's homes, sharing information, how to keep yourself safe.
Hmm.
how to get treatment. And then there were some renegade healthcare practitioners who joined forces with these people, these activists, became
Hmm.
activists themselves. And together they managed to change health policy in the country. They managed to get the Ryan White Care Act passed and lots of federal funding for services.
Yeah.
And written into that, a requirement that community members, people affected, people with HIV and people from very affected communities had to be a part of the decision-making process, distributing monies on the community level.
Yeah.
You know, they had to be a part of setting scientific priorities at NIH.
Hmm.
So it was a real revolution. This was what I was encountering as a young person,
Hmm.
you know, trying to decide on grad school and my life. So that's what inspired me. And what I figured out was that there were actually so few people doing social research in medical spaces
Yeah.
that if I joint trained in, at that time I was thinking of other things, sociology, I wasn't sure. I ended up in anthropology, but
Hmm.
if I joint trained in social science and also with a focus on community-based research, but also trained in medicine so that I was an insider, because it's a very tight network and
Yeah.
closed network.
Yeah.
People from outside medicine have a very hard time getting inside. And that's been the experience of many of my colleagues in social sciences, that if you're not seen as one of them, very hard to get in. So I thought, okay, I'm going to joint train
Yes.
and try to bridge and import. I was really focused on importing social science into medicine, but it also works the other way in that many of our social sciences, anthropology high among them, are suffering a little bit of a crisis of relevance and public investment.
Yeah.
And so if they can show how they're critical to improving things like health, which is, you know, a shared priority, you
Right.
know, many people really think of health and healthcare is very important, then social sciences also win out in
Right.
terms of getting the resources they deserve. So
Right.
that was my vision. And then when I was entertaining coming from NYU, where I had spent over a decade in both the anthropology department and the psychiatry department at the medical school, when I was entertaining coming to UCLA, the thing that grabbed me was that the dean really wanted to start a new research theme that would bridge social sciences and medicine and really rigorously address social determinants of health. Because in
Right.
academic medicine, it's the level of sophistication is quite low
Hmm.
about what is the social, right?
Hmm.
In
Hmm.
medicine, we often boil it down to a couple of questions in a survey, as opposed, or data points in a medical database, as opposed to picking apart, as a careful social scientist would do,
Right.
what is the mechanism? What are the
Hmm.
social mechanisms driving these inequalities? How does it actually
Hmm.
work? Very little
Hmm.
sophistication about that in academic medicine. So I suggested to the dean at the time, why don't we call it, she wanted health equity,
Hmm.
because this is, 2020,
Hmm.
COVID inequalities, Black
Oh
Lives
yeah.
Matter taking to the streets, a lot of
Oh yeah.
attention, you know, very conservative clinical journals, including
Hmm.
New England Journal of Medicine and Journal of American Medical Association, all of a sudden publishing articles with structural racism in the title, where we
Hmm.
had never seen that before.
Hmm.
So, she wanted to have health equity. And I said, okay, but let's also put translational social science.
Mm.
Because in the world of academic medicine, it's translational science, meaning we take insights from the bench to the bedside, the laboratory bench to the bedside. And I've always made the pitch throughout my joint career, we need insights from the field,
Hmm.
the community, or whatever the unit, the institution, to the bedside, right?
Yeah.
So
Yeah.
the idea is translational social science is social science that can really illuminate health and healthcare.
Wow. Wow. Thank you for that. I mean, intersectional, comes to mind as a way of kind of, talking about different disciplines kind of interacting with one another. So I love that translational, because I think sometimes what happens in your community and how that potentially plays in your healthcare, sometimes that gets forgotten. So I'm really excited that there are, academics out there who, one, are MDs that are also making these comparisons. So thank you about that. I think throughout, a piece of a word throughout the through line that kept coming forward for me was we. And I always think about some of these, especially on the medical side of, I'm going to say the medical side of your brain, that we a lot of times doesn't have the same equity, as it relates to a narrative. So can you talk about just like some of what you've seen through your research as it relates to different communities and how, some of this is playing out?
So how inequalities evolve or how they're addressed in
Yes,
academic medicine?
definitely.
Yeah, I mean, academic medicine is kind of, how can I explain? One reason why social sciences, including history, are so important for academic medicine is that they don't have any self-awareness.
Mm,
Those of us who work strictly within academic medicine, many well-intentioned colleagues puzzling at how we could arrive at this point where we invest so much money, we have such high technology, and yet people are dying, on the doorstep without care.
mhm.
How could this be? And especially, what's the role of medical schools and academic medical centers in that, without any awareness of the history, how we got here, and the reason that so many medical schools, UCLA is the exception. It's kind of weird that UCLA Medical School is located in a really rich white neighborhood between
Mm,
Bel Air and Beverly Hills.
mhm.
And that's a whole other story. I can get to that in
Yes.
a moment. It's
No,
led to a
no.
very strange dynamic. But most medical schools in the US are located in historically poor Black and brown neighborhoods. So if you
Mhm,
think about Johns Hopkins in Baltimore, you think about um, in New York, many of the med schools, I've spent time at Columbia up there in Washington Heights, and
mhm,
NYU, which is located in what was previously a very poor neighborhood across the street from a housing project.
mhm,
Most medical schools in the States are in these poor Black and brown neighborhoods for a reason. They
mm,
needed research subjects, they
mhm,
needed bodies to train medical students on.
mhm,
So there's been a whole, and we know with racial, we still have medical apartheid, but we have a
mm,
very long history of segregation whereby many poor Black and brown people could not get medical care in the elite institutions,
mhm.
except perhaps through experimentation.
Yes.
Um, and so
And weren't believed is some may talk about as well, right? When they did show up.
Right, right. So yeah, in the case of, yeah, all over, across the board, I would say American medical schools have been actually a big agent of race and class segregation.
Mhm,
They have not
mhm,
been the solution to it. They have been
mhm.
taking advantage, exploiting it, and propagating it.
Yeah,
And they still provide two tiers of service. Just
yeah.
about any med school I can imagine in the United States right now has two tiers. They have the tier that will accept Medicaid patients, where it's largely populated by students. A lot of clinical trials run through it. And then they have the tier, it's usually called the faculty practice or something like that, where you can go and get state of the art technology if you're very wealthy. And so, as medical trainees, students, residents, we often experience this cognitive dissonance. I'll just quickly describe at NYU, where I did my residency, that we essentially had two hospitals, two main
Mhm,
hospitals. One was Bellevue Hospital, the city's largest public hospital,
mhm,
um, primarily Medicaid uninsured patients. Lot of Black and brown, in any given day, 181 language groups,
mhm,
immigrants from all over.
mhm,
3 blocks up the street is NYU Hospital.
mhm,
3 blocks only. They're both on First Avenue. One is
mhm,
at 28th. The other one is at 31st. They're
mhm,
only 3 blocks apart. NYU, so you enter Bellevue Hospital, and it's actually a pretty nice, they did some renovations about 20 years ago, so it's got
yeah,
a nice entryway, but it's an old building.
yes.
It's cracking in the corners. There's a lot going on there.
Mhm,
You go 3 blocks up, there's NYU Hospital, which has, like a goldfish pond and a fountain in the middle and a pianist, and
right,
it's just valet service.
right.
And I was training in psychiatry. You go to the
Yeah.
psychiatry unit at NYU Hospital, and a lot of the patients are sons and daughters of celebrities or professionals,
Mhm,
doctors, whatever.
mhm,
It's NYU, and there's an elaborate entertainment center and recreation center, and the nurses are very highly trained and
mhm,
spend
mhm,
a lot of time with you. And then just 3 blocks down the street at Bellevue Hospital, you're talking about a ward where a lot of people are in restraints.
mhm.
Um,
Medically or physically, right?
yeah,
Mhm,
both.
mhm,
Uh, the police, one floor of the hospital is a part of the New York jail system. It's a part of Rikers, people
Mhm.
coming in and out in handcuffs, very, very different. So you get this, it embodies the two tiers of healthcare in the
Mhm.
United States. You literally get trained in that. You get trained that you deliver one type of healthcare up at NYU and another type of healthcare down at Bellevue.
Mm.
UCLA being a little weird because we don't really have a public hospital that we're affiliated with, and we're in such a rich area that we almost lack one of the tiers, and
Mhm.
that's a whole other problem. But this was a long-winded way of saying we don't have any self-awareness
Yeah.
in academic medicine about what creates these huge inequalities, and it's kind of tragic that we don't realize we're actually perpetuating and creating the inequalities in the very way that we train and do our research.
Right, right. But you have a new book that's coming out, correct, Doctor? And in that, you are going to help us get on the track that we should have been on, correct?
Well, thanks
Tell
for
us,
saying so.
Tell us a little bit about the research that you did within your book and the book itself.
Sure. Okay. So the book is entitled Whiteout: How Racial Capitalism Changed the Color of Heroin in America. And
oh,
it's kind
wow.
of, it's deliberately melodramatic, but it's being released in a year that we got the first reports that overdose deaths in the United States among Black Americans exceeded overdose deaths among white Americans. So
Mhm.
2020 was the first year, going into 2021 was the first year that that was the case for the past couple of decades.
Right.
So
Wow.
we're on the heels of 2 decades of what has widely been thought of as a white opioid crisis, the
Mhm.
white American opioid crisis. And the
Mhm.
perception of it as a white crisis has changed everything about drug policy. Well,
Right.
everything and at the same time, nothing.
Right.
On the theme of 2 tiers of healthcare,
Yeah.
we've
Yeah.
seen 2 tiers of drug policy. So I'll give you an example. Since the late 90s, when OxyContin was approved, for quote unquote moderate pain and use in general doctor's offices,
Okay.
and the manufacturer heavily marketed it to a white and often suburban and well-off insured, basically a white insured population,
Mhm.
and got around regulators because of the perception that these were white patients that weren't at risk for addiction the same way that Black and
Mhm.
brown patients were. So the OxyContin moment of the late 90s,
Mm.
followed by these news reports of the shock that white Americans were using opioids, the
Wow.
utter shock. So there, I've done newspaper content analysis,
Yeah.
analyses of this period, the early 2000s, and then again in the 2010s to 2015s. There were
Mhm.
these headlines, new face of addiction.
Mm.
Okay, so it
Mm.
started with, in the early 2000s, the new face of addiction, as
Right.
though, and always white, usually blonde women. Okay,
Yes.
it was very gendered too.
Right.
This was the suburban housewife that had back pain and got
Mhm.
OxyContin and then found herself,
Mm.
really hooked and buying pills on the street. And
Mhm. Mhm.
it was very gendered. So, and this was all deliberately crafted
Mhm.
because in the 1990s moment of deregulation at the FDA and deregulation of pharma and the decade of the brain in general, this belief that on the heels of the Human Genome Project, we were going to have these flashy technological solutions to
Right.
problems like addiction that we long thought of as these complicated, intractable social problems.
Mhm.
So the manufacturers really dug in and took full advantage of this. And
Mhm.
one of the ways they were able to do it was to really foreground the image of the white person
Mm.
as the intended consumer,
Mhm.
got around the regulators, did aggressive marketing, lots and lots of pills being sold in predominantly white areas of the country. So with all of these different things happening by 2008, I'd say we were, at the peak of our prescription opioid overdose death
Right.
crisis.
Right.
And as a solution, there are all sorts of new drug policies geared towards getting medical treatment to these people as opposed to incarceration.
Mhm.
So very,
Mhm.
very different
Response.
tone. A whole field of addiction medicine was invented and propagated.
Right.
A medical solution called buprenorphine, which I've
Mhm.
spent 2 decades studying because I first encountered it as a medical student. I was working under a professor at the med school who's running the early clinical trials of buprenorphine, otherwise known as Suboxone. It was supposed to be the magic bullet solution to this white suburban opioid overdose problem.
Mhm.
And it was unlike methadone, able to be prescribed by private doctor in an office. Someone could go and get, a month's prescription with 3 refills and take the medication at home every morning, which is totally different than the methadone system.
Very
We're
much
talking
so.
about a medication that is pharmacologically the same thing as methadone. It's an opioid that blocks opioid receptors so that illegal opioids like heroin won't have the same effect.
Right.
Same concept, but a whole new treatment track was invented with a white market in mind.
Wow.
And that's what my book is about. Preponderance of evidence that it was the white consumer all along.
Right.
2008, that same year, incarceration rates, a lot of them linked to drug war policies peaked. So you see how the 2 tiers work?
Yeah.
Because a
Definitely.
brand new drug policy geared towards white America was invented and really taking off by 2008 at the very same time, very same moment that incarceration rates were peaking among Black and brown Americans. So that's the 2 tiers right there in your face. And you can actually see the 2 peaks if you graph it out in terms of the response, the response. So now what we have, we can no longer say it's a white crisis.
Right.
And it's very complicated how it became Black and brown, because it's right now it's really Native Americans and Black Americans that are really dying off. Their overdose death rates had begun to really accelerate around, well, as early as 2013, but by 2017, really sharp, steep curve. By 2020, exceeded white overdose death rate. The story of how that happened is again linked to the 2 tiers in many ways, because Black and brown Americans, so unlike white Americans who had been really targeted with initially legally prescribed prescription opioids, right? Opioid pills, manufactured pharmaceutical grade pills. So Black and brown people have, by design, because drug policies have been racialized for the past century, they have been associated with illegal markets. And illegal markets associated with them, right? And so initially, Black and brown people had a very hard time even with legitimate pain complaints, very hard time getting prescribers to give them these newly patented opioids in a doctor's office. That's very well established that Black and brown people come in with, long bone fractures, can't get opioid, couldn't in the late 90s when it was being pushed the heck out of among white patients. Black and brown patients could not get treatment for bone fractures and serious pain. But the illegalized heroin market was, of course, located in their neighborhoods by design, and very much geared to them, right? And so, and located in port cities that have significant Black and brown communities. That's where heroin trade had long been established. And so initially what we saw was prescription opioid deaths that then began to transmute to heroin when the white tier of drug policy moved in, medicalizing the people who were using prescription opioids, but cracking down on prescribers and pharmacists. So we had prescription drug monitoring programs, unprecedented that doctors were monitored and actually had criminal charges against them if they didn't check databases to see in their state whether a patient had been prescribed narcotics elsewhere, from another doctor, things like that. So in order to avoid arresting the prescription user,
they put the onus on the medical professional.
Yes, and believe me, this was a big deal. The AMA was protesting, and like doctors were not used to that kind of oversight and criminal intervention. So that was one thing. But what this did was the supplies, along with tamper-resistant formulations of opioids that the manufacturer came up with to keep the patent going and to keep the profit margin going. And to respond to these public health concerns with yet another technology, yet another magic bullet. What happened was this group of white people in suburban and rural America that had been marketed the early prescription opioids were stuck without, they were physically dependent and stuck without an opioid. So they turned to heroin markets. And we saw a growth in heroin markets in rural and suburban America as a
Right.
result. Big market, they're just waiting to be supplied. And then fentanyl and
Yeah.
other synthetic opioids that are much more potent.
Yeah.
So, it takes 1/100th the amount of fentanyl to have the same effect
Mm.
as heroin.
Hmm.
That means that you only need a tiny amount. You only need to smuggle a tiny amount.
Right.
And so fentanyl markets took off and started replacing heroin markets. And this has been very toxic, both for white people,
Yes.
but especially for those Black and brown communities that had long established heroin markets and that were experiencing really heavy law enforcement and incarceration.
Mhm.
Because people, it's really well established that the period of weeks to months right after you're released from jail or prison,
Mhm.
if you have a history of opioid use, very, very sensitive time,
Yeah.
high risk time for overdose, because your body doesn't have the tolerance to opioids that it might have had when you first were incarcerated.
Right.
You're under incredible pressure,
Right.
social pressure. You don't have a job, most people won't hire you. You're
Right.
legally barred from a lot of public services, including housing. You often
Right.
don't have medical care. You don't have drug treatment. You're under tremendous stress and risk of relapse. And you don't have services at the same time. So then you're going to a drug market that is way more toxic and unpredictable,
Right.
which has
Right.
fentanyl in it. So
Right.
these are the kinds of things you're talking about, intersections.
Yeah.
These are
Yeah.
different intersections of structural risk for Black and brown people that were created by this whole racialized trajectory,
Right.
but now they're being caught at the other end, kind of catching the consequences of the early marketing that the legal opioid manufacturers started in the 90s. So
Right.
it's kind of come full circle. And it turns out that this is not, speaking of history again,
Right.
this
Right.
is not new. It turns out that virtually all of the drugs that we think of as these really dangerous illegal drugs,
Mhm.
including cocaine, methamphetamine, whatever, these are substances and heroin,
Mhm.
all of them are substances that began as drugs for a white middle class market, all
Right.
of them. So, throughout the past century, Black and brown people have been demonized as the quintessential addicts
Mhm.
and the
Mhm.
ones that are in danger of bringing drugs to white neighborhoods. We had wave upon wave of drug scares and moral panics around these Black and brown dealers that were going to bring drugs to white suburban communities. And it turns out
Right.
it's the exact opposite,
Right.
that
Wow.
these drugs were all introduced to a white middle class market
Mhm.
and then filtered to Black and brown poor communities later. So
Wow.
it repeats itself over and over again, which is
Right.
of course not something that any of my colleagues at the academic medical centers would really think about
Right.
in reading this history.
Right. Or probably would not have the academic history to speak to it as well, I would assume. Because a lot of times within a discipline, you learn just about what it is you are interested in. And that's why history is so important. Um, Dr. Hanson, thank you so much. Tell us once again the name of your book and when it's going to be available to us.
Sure, it's called Whiteout.
Mm. Mm.
How racial capitalism changed the color of heroin in America.
Definitely.
That's my dog. And I
He's just clapping for the book title there.
That's right.
Give us a little bit of a clap there.
Right. And I have two co-authors, sociologist and policy analyst Jules Netherland, who's at the Drug Policy Alliance, and
Okay.
David Hirschberg, who's a drug historian of race,
Okay.
because we wanted to weave together both the ethnographic and social analysis that I have with history of the last century, how the opioid crisis represents a repetition really of something that began with heroin, which was
Definitely.
introduced by Bayer Pharmaceuticals in 1898 for Victorian
Definitely.
housewives for menstrual cramps and lower back pain. It was thought to be a non-addictive substitute for morphine. It was also a cough syrup for children.
Wow.
So heroin was a middle-class white drug that was demonized 20 years later when prohibitionists needed
Mm-hmm.
to pass prohibitionist policy. One of the quickest way to do that is to associate something with Black and brown people.
Yeah.
And so you saw stories.
Wow.
So you saw stories about Chinese opium dens luring unsuspecting white women into sex
Mhm.
slavery. You saw 1914 New York Times, cocaine-crazed Negroes in the South were
Yeah.
attacking their work supervisors. This is how we got the policies outlawing heroin and cocaine, which had been, over-the-counter products and
Mhm.
everyday, items in
Right.
households.
Coca-Cola, right?
Yeah,
One of the most
Coca-Cola.
famous. Yeah.
Yeah.
Mhm.
So where was I? Okay, so we introduced deliberately, so we wanted historical analysis, we wanted a policy analysis, and then I had my ethnographic, anthropological, sociological analysis. And we wanted to use racial capitalism,
Mhm.
because right now in medicine and public discourse, we're talking now about structural racism
Mhm.
in ways that we hadn't really before. So that term has really taken off.
Oh yeah.
But racial capitalism is particularly important to understand. It's important to understand how corporate entities, and this is quite visible in medicine, have tapped into racial hierarchies to make profit.
Yeah.
It's baked in, so the story that we have to tell about opioids is illustrative for a lot of other issues in our society, the ways
Mhm.
that we're seeing inequalities actually as a natural product and actually something that our capitalist system exploits.
Yes.
So we can't really separate our economic system from our racial hierarchies. They're co-created, mutually intertwined. And of course, racial capitalism, a term coined in the 1980s by Cedric Robinson,
Mhm. Mhm.
who was arguing with Marxists
Yes.
who wanted to say that, racial divisions were really just class divisions. And he was
Yes.
drawing on a century of Black scholarship to argue back that no, actually, you cannot understand class without race.
Right.
The two are mutually intertwined. The whole system of slavery, of course, being an economic system that relied upon it. But now this is our chance to modernize it with, for example, the story of pharmaceuticals and healthcare industries, because in 2022, racial capitalism is alive and well. It may
Yes.
not be embedded in a legalized and explicit form of slavery, but it's definitely embedded in our consumer markets,
Yes.
not only in our production, but also in our consumption.
Yes.
Pharmaceutical industries are well aware of this and they exploit it. Healthcare industries are well aware of this and exploit it. UCLA Medical School, I know I'm going to be fired for this, but there was
No one gets fired.
UCLA health system is well aware of this and exploits it,
Yes.
So
Yes.
we need much more sophisticated understanding about how race and economics co-create each other.
And I think you have done an excellent job today here on LA Social Science, just kind of connecting the dots for us. And, that's why when I initially started out, I talked about how excited I was to speak with you today, because I had gotten a chance to hear you connect the dots. And now the folks who may tune into this will get that opportunity as well. Dr. Hanson, thank you. No, thank you so much for your time today. And I really look forward to having another opportunity to interact with you.